Welcome, everybody. My name is Jim Rodriguez. I'm the facilitator of this panel discussion. Welcome again to the Mental Health Stigma Roundtable discussion series. This is our second roundtable looking at the experience of mental health stigma among diverse groups. I want to thank you all for joining us today. As I mentioned before, we have over 500 people registered, so I see the numbers going up as we speak. I want to take a moment to welcome you. And then I also want to sort of bring in two folks who have been instrumental in making this roundtable series happen. Suzanne Feeney from the New York State Office of Mental Health and David Minot from Mental Health News Education. Suzanne.
Thank you so much, Jim. Hi, everybody. Thank you so much for joining us this afternoon. We're really excited to have you all here, and we're really excited about what I think will be a terrific panel discussion. As Jim mentioned, my name is Suzanne Feeney. I am Director of Program Management within the Office of Mental Health, and more specifically, I work in the Office of Advocacy and Peer Support Services. I've been with OMH for about 5 years. And I think it's important to share with you that in support of OMH's strategic plan for statewide stigma reduction, we have been partnering with Mental Health News Education. Our strategic plan for statewide stigma reduction was officially approved in October of 2021, and we're now, I think, about 15 or 16 months into our work. Today, as Jim mentioned, is number 2 of 4 in a very important series and a key intervention. And we're really looking forward to having your participation and your input. Our partners, Mental Health News Education, have chosen the panelists and have worked really closely with us, myself, Dr. Colón-Wagner, and others to plan the content for today. And we really hope that you find it worthwhile. We also are asking you to be on the lookout for another important intervention, and that is the second special edition of Behavioral Health News. Behavioral Health News is published by Mental Health News Education, and we last year did a special edition dedicated to stigma. That was the first special edition. We have a second special edition, and the call for papers and articles has come out. So please be on the lookout for that. That edition is going to be titled Stigma and How We Can Make a Difference. Once again, thank you all for joining. David, I'll hand it over to you.
Thank you, Suzanne. My name is David Minot, and I am the Executive Director of Mental Health News Education, the nonprofit organization that publishes behavioral health news and autism spectrum news. Our mission is devoted to improving the lives and delivery of care for people living with mental health concerns, substance use disorder, and autism, while also supporting their families and the professional communities that serve them by providing a trusted source of science-based education, information, advocacy, and quality resources. In addition, we provide a platform for our readership to communicate and discuss important social issues in an effort to reduce the harmful effects of stigma in the community. You can access our free library of over 2,500 educational articles in both publications by visiting mhne.org. As Suzanne mentioned, part of this collaborative project is for us to publish 2 special stigma-focused issues of behavioral health news. The first issue was focused on understanding the impact of stigma and features over 25 quality articles written by experts on the subject. You can actually view this issue online by visiting behavioralhealthnews.org/archives and click on the link for the summer 2022 issue. I'll also be posting a link in the chat. The announcement for the second stigma-focused issue of Behavioral Health News, which will be devoted to the theme Stigma, How We Can Make a Difference, will be released in early April. We recently sent out a request for articles with the list of suggested topics, and we will be posting a link in the chat for you to view this issue announcement. And now I would like to introduce you to our roundtable facilitator, Jim Rodriguez.
Thank you, David. So before we get into the panel discussion, we're going to go over a few housekeeping guidelines. And thank you. And so just, when logging in, use your full name so we know who's out there. And this will also assist for CEU tracking. There'll be a Q&A at the end, so please type your questions into the chat as you think of them. And just a couple of disclosure, all the panelists and planners have no financial relationship to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products. The roundtable is approved for CEUs, and I'm going to say a little bit about CEUs in a minute, but if anyone has questions about CEUs, you can contact Colón-Wagner. On this next slide, we just want to go through a few mention that, again, as I said, they are approved for CEUs for social workers, psychologists, and peer specialists, and CMEs for physicians. Here are each of the professional accreditation statements to that effect. Next slide. And again, just a reminder, this is the second of 4 roundtables. The next roundtable will be in 2 weeks. And in that roundtable, we're going to be looking at the role of the media in reducing stigma. And then roundtable 4, paths to reduce stigma and promote positive attitudes. At that roundtable, we're going to have many folks who are related to the many organizations that are working to advocate on behalf of people with mental health challenges to think about our future directions. Next slide. And then just a couple of guidelines for discussion. As I mentioned already, you can type your questions in during the panel discussion. And just a couple of things we want to encourage you to do. You can use closed captions if you'd like. You can click the show captions button. If you don't see that, just click on that little thing that has 3 dots and you can find closed captioning if that's something you need. We also recommend that you put your speaker or your view on speaker view on the top right corner. You can put it in speaker view so that as folks are talking, you can just see them in screen. And then just a few things for discussion. We ask for information as we move forward to be clear, not to use jargon. If any jargon's used, we'll try to explain it in the chat. Be open to alternative views. Be comfortable with unfinished conversations. As I mentioned before, this is a series of 4 roundtable discussions, so we're trying to cover as much as possible. There may be aspects of the discussion that we'll be covering in future roundtables. Practice self-care. We realize this topic can bring things up for folks and be discomforting for some folks. So if folks are feeling you need to take space, walk away. And of course, you can always contact 988 if you need mental health support. And please feel free to challenge respectfully as we move forward. And also for those folks who would like to share your experiences, as our panelists will do in a few moments. Next slide. So I just want to cover a few disparities that we know of among diverse groups in mental health. So data suggests that African Americans are more frequently diagnosed with schizophrenia and less frequently diagnosed with mood disorders as compared with whites exhibiting the same symptoms. Asians received the lowest amount of mental health services in the past year. This was in the year 2017 compared to non-Hispanic whites, Hispanics, and Blacks. The rate of suicide attempts is 4 times greater for lesbian, gay, bisexual youth and 2 times greater for questioning youth than that of heterosexual youth. Studies have shown that older Hispanic adults and youth are especially vulnerable to psychological stresses associated with immigration and acculturation. And rates of depression are lower in Blacks and Hispanics than whites, but is more likely to be persistent in the lives of Blacks and Hispanics. And these are just some data around the disparities that we see in mental health. There's many more. And then very quickly, a very important topic with regards to thinking about mental health stigma among diverse groups is this notion of intersectionality. So intersectionality is the recognition that an individual's experiences and opportunities are determined by their multiple intersecting social characteristics like gender, race, ethnicity, age, social class, and others that expose them to diverse systems of oppression. This idea of intersectionality came from Black feminists who were concerned about their role in the larger women's movement. And they wanted to bring to light the issue that gender and racial discrimination intersect to create unique forms of oppression that can't be explained, understood, or overcome if you only look at one aspect of a person's identity or the forms of discrimination they're exposed to. The intersectional stigma of mental illness, I believe coined by the mental health stigma in the mental health stigma issue of behavioral health news that we talked about earlier by Professor Maria-Elena Lekos and others who's joining us today. She defines it as the systematic process of exclusion or privilege, generating vastly different stigma experiences among persons with mental illness based on their race, ethnicity, gender identity, sexual orientation, and or other marginalized groups. And to put it kind of simply, not to be glib about this, but the theory is basically that if we could snap our finger right now and eliminate mental health stigma, according to this theory, right? And we could do that today, right? But we did nothing about eliminating any of the other forms of discrimination that exist, like racism, sexism, xenophobia, classism, homophobia, anti-Semitism. If we didn't eliminate those other forms, then anyone with mental illness who also has any of those other characteristics would still face discrimination and oppression and marginalization. So that's the theory. But here today, we have a panel who can talk about this intersection of mental health challenges and other parts of their identity in a personal way. But before we turn to the panel, we want to have you all contribute to a word cloud that we'd like to. And in the word cloud, what we want to do is enter words that reflect the multiple identities that have influenced your life experiences. And by multiple identities, it could be personal or social identities. Personal identities are the things that make you unique. Could be your profession, hobbies that you enjoy, things that you like to do in your life, things that make you unique, or your social identities. And your social identities is the identity that you derive from being a member of other groups, like racial or ethnic groups, the social, sexual identity, gender identity, and other groups that you belong to. So please feel free to enter into the chat, and it's in the chat right now. You could enter multiple identities, and if you need to go back and reopen, you can add additional identities as we move forward. So with all that said, I'd like to turn the discussion over to our panel. Very quickly, our panel is made up of Darlene Carrera, who's a clinical trainer on OnTrack, the Center for Practice Innovation. She's also in the leadership of the New York Coalition for Asian American Mental Health. Ruth Colón-Wagner, who's the CEO and Executive Director of BCS Inc. Kim Kaiser, the Director of Diversity, Equity, Inclusion for Families Together New York State. Randy Killings, Director of Peer Services at the Rainbow Heights Coalition, and Catherine Roberson, who's a postdoctoral fellow, Mental Health Equity Institute for Health and Equity Research at the Icahn School of Medicine at Mount Sinai, and Tiara Springer Love, the Director of Youth Power for Families Together at New York State. And then we also have two researchers, Helen Maria, or Maria-Elena Lekos, the Director of the Center for Research on Cultural and Structural Equity at the Nathan Klein Institute, and Dr. Phil Llanos, Professor at John Jay College of Criminal Justice, the City University of New York, Psychology. So let's bring in our panel. And so for our panelists, what I'd like to do is, as we've discussed, right, there are many aspects of our people's background or identity that can make a difference in their behavioral health challenges. And by background identity, just to be clear, we're talking about aspects of your identity that include the communities that you belong to, the languages that you speak, where your family's from, your race or ethnic background, your age, gender, sexual orientation, gender identity, faith or religion, could be any of those things. And so what we want to do is ask you also to talk a little bit about the important aspects of your background identity. And then please share with us, are there aspects of your identity or background that have made a difference, positive or negative, in dealing with mental health stigma in your life? And so I'd like to start by bringing in Darlene to start us off.
Hi, everybody. I just wanted to say thank you for this opportunity to speak. I was an audience member for the first panel and want to say that I was truly inspired by the stories, and I really do hope that my story experience can intersect with others in this conversation. Just to start, my name is Darlene Carrera. I am a Filipino American woman, second generation. I am also a clinical social worker and work currently now at the Center of Practice Innovations at a program called OnTrack. I'm also a mom. I would say that I'm an artist, and I'm a person with living experience with mental illness. And so the part of my story that I do want to share has a lot to do with my experience with mental health stigma when I was quite young. Again, my parents immigrated from the Philippines at a very young age. And I think that for them, they were really wanting to be part of sort of the majority society. They wanted to acculturate well. And so a lot of pressure was put on myself and my siblings to do well, to pretty much live the American dream. And I think part of the issue, connecting myself to just being sort of Asian American, is having the model minority myth be part of my, sort of identity. And I think that during a time when I had brought up to my parents that I was really going through some, major things in my adolescent years, this was not part of their narrative for me, right? So the model minority myth is that, we are high achievers, we're hardworking, we don't need help, we are self-sustaining. And I think that in that false narrative, my parents really didn't recognize it. We didn't have the words for it. They did not want for me to have this label in fear that this would be sort of tainted, with our family. And it was not part of just their, thought process of me sort of achieving and sort of helping with the family. And so I think, just to sort of avoid any sort of disappointment, embarrassment, what they did tell me was, you'll get over it. You're a hard worker. You need to just pray about it. And it sort of moved on in that kind of direction. I think in turn, because there was also that sort of push to be academically, successful, I was still curious about mental health. And so I went in that direction to learn, right? And so I went to school and was the first person in my family to get a master's degree, and really spent my whole entire career learning about mental health, just because that was something that wasn't really quite given to me when I was young. And I think that definitely does play a huge factor in what I do now. I think that part of my sort of journey is, talking about these kinds of issues, talking about some of the stereotypes and myths that really don't help with, mental health illness. I think also that, the sort of push to be successful and to pretend like this doesn't exist really kind of hurt me in my wellness growing up. And so I think that, this is what helped me to sort of move forward in having a voice and speaking my truth and sharing it with others. So I think I'll stop there.
Thank you, Darlene. Kim, can you share a little bit of your experiences as well?
Yeah, and I really identify with Darlene's experience being the first person on the maternal side of my family born in this country. That comes with a lot of weight. It comes with a lot of weight to achieve. So for me, I exist at the intersection of being a Black woman, of Caribbean descent, of Caribbean, Latino, and Jamaican descent, East African descent, as well as African American descent. And in terms of my faith-based, my whole life has been inundated with my intersectionalities of Rastafarians, Southern Baptists, and Jewish roots. And these types of intersections impacted me because I witnessed a very faith-based approach to what would be defined as bad behavior or things you just need to get over. And all of that intersected with the deep-seated stigma around all types of disorders, the effects of trauma, and other behavioral health diagnoses. But this all I understood very early on, because I grew up in a family of advocates, that all of these things were very rooted in the stigma that has been fostered through our historical trauma within our communities. It was very difficult at times to help others cross that threshold into health and wellness, to buy in to clinical interventions in my family, in my community, because they were so deep-seated. So for me, I just really want everybody to understand that these things, whether it was a century or 2 centuries ago, these things continue. When the Black community was diagnosed with a mental health disorder just for not wanting to be a slave, moving forward from slavery to Jim Crow to everything in civil rights continually to today, the stigma is very much ingrained for very good reason. You could not be mentally ill and be a slave. A mother with a child with mental illness had to hide that child, because that child could be taken as chattel and sold as a toy to a white child, or even worse. So the fear has ingrained in my community, in my culture, in my family, this very much standoffish approach. But within that, the benefits for me in my community is that I was fortunate enough to grow up in a family of advocates, as well as clinicians, as well as researchers. So I was able to witness the ability to provide cultural adaptations to the work, to be able to push forward the narrative of clinically based, evidence-based modalities, but also to understand the need to accommodate an individual and validate that individual's culture and their language, their culture, their spiritual beliefs. So that impacted me very deeply, because I've seen too many lives lost. I've seen too many people incarcerated within my family. I've seen people die from substance use disorders, lots of things attributed to a variety of intergenerational traumas and other behavioral health diagnoses. So that's basically who I am. But lastly, I want to say at the core of that, I'm a mother and I'm a fierce advocate. I am the parent of a child with autism. I am the foster parent of a child with autism. I'm the step parent of 2 children with mental health disorders. So I stand firmly, because there by the grace of God go I, there by the grace of God is every other family from my culture. So it's very important to break the stigma, because some of this was very, very challenging to me as I was growing up, to try to communicate some of the things that fed my belief that there is hope within these systems that have marginalized us for centuries.
Thank you, Kim. Thank you. And Randy, can you share?
Hi, everyone. My name is Randy Killings. I'm the director of Rainbow Heights Club. Rainbow Heights is a psychosocial advocacy program for LGBTQ people living with mental illness. Who is Randy? Randy is a son, a father, a brother, a singer, a dancer, a partner. I'm gay. I got mental illness and I have a lot of incarceration history. All that was kind of how I had to deal with my life and try to figure out who I was. Like the 2 before me shared, and thank you, ladies, I grew up in a middle-class area. We were poor, but an upper-class poor, I want to say. We lived well. But my moms would not take the suggestions as in grade school and kindergarten that something was wrong. I talked to myself. I was hyper. I was diagnosed with so much. And at an early age, I knew that I was gay. So unlike the young lady said before, she had to get over it. We were told not to, I was told not to get over it. You had to mask it. My moms did not want that to show. In my community of Black families, mental illness was a no-no. It was something that no one wanted to say was happening in their family. And basically because it would always reflect on the parent or someone else in the family, which had nothing to do with them. And because of that, I did what I saw when people were going through things. I got into drugs. I got into drinking and fighting, because that was the only way to mask what I was going through. And because of the mental illness and being shuffled in different places, I experienced some trauma. And that made me angry, and that made my drug use increase. And that was the only way I could deal. And then with the anger, I went to jail so many, I think I have like 26 years of jail. And I just came out in 2009. And in that time was the first time I met someone that was basically a person that would listen to me and find out what my problem was and how they could help me. It wasn't a cookie cutter thing, and took time to share some things about mental illness that I didn't know. Why? Because I never got treated. My mom was not letting the yellow bus come, and I was definitely not being drove to a psychiatrist, because that means she would have to go in and they would think she was being evaluated too. So, you know, you grow up doing the best you can. And one of the things that helped me be open to this person that I met in prison, she said, well, I commend you for taking care of yourself. And she applauded my efforts for trying to do the best I can. And that was a new dialect, because everybody shamed and blamed me and called me all kind of names for doing the best I can. And this lady opened me up to being a part, having a discussion on what was going on with me and how I wanted to work with it. And that was the dynamics that changed my life. And coming out of prison, I was able to feel different, be different, and do different. And then break the paradigm in my family, which is some things are still going on, but I'm a representation that you can break the paradigm. And I kind of role model and got into what I'm doing, because I want to role model to people that you're more than your diagnosis. You're more than just a junkie. You're more than just a person that came out of jail. And if you have the right person sitting in front of you doing their job and not bringing their perspective of what's best for you, that which wasn't helpful for me, because I was always told what I should do. And being gay and coming from a religious family, it just didn't work. But I found myself, and somebody helped me with that. And that's where my life began to soar. And I really wish that people get that stigma hurts. And not only does it hurt, it prevents people from living their potential. Thank you.
Thank you, Randy. And in the next piece, we're also going to talk a little bit more about what we can do to help and how we can reduce or mitigate the effects of stigma. Ruth.
Hey everyone, I'm going to copy Randy's intro. Who's Ruth? So I'm a mother, I'm a wife, I'm a sister, I'm an auntie, and I said wife, right? Yes, yeah, he wouldn't like that if I left him out. But essentially, when I was thinking about these questions, I've got all these identities that intersect with mental illness in some way, shape, or form. And so I'm deciding to talk about personal and professional. And so many people, if you know me, you know that I am the parent of an adult child with mental health challenges. And those experiences completely impact the entire family. And I've been a professional much longer than I've been a parent of a child with mental illness. So it was a new experience for me, and it was a perspective for me as well. And I was looking out for her, and my intersectionality was with her mental illness. And I wanted everything the best for her. I was desperate for her to just get better. And I exploited every connection I had ever made in this field, because if anyone could help, an insider could help. And basically that did help. And I always fear for people who don't have the connections that I did. I was blessed to have. So my personal experience with mental illness really was a result of her illness. And so there came a point where she was just so so bad that I started to exhibit anxiety, debilitating anxiety for like 2 months. And thankfully, I worked for an organization that understood that very well. But the journey had me questioning, what is peerness, right? What does a peer mean? What is the definition? And I kept asking, what's the definition of peer? And obviously the definition is dependent on who you ask. And so as a CEO, I think about the professional aspect of our work, and we should all really be embracing all of our staff in an environment that fosters the sharing. So provide an environment to share, a safe environment where it's okay for the staff to share. And I'm not talking about peer staff, because peer staff, and by the very nature of the job description, you have to have a lived experience. It's all the other individuals that we work with, that's not part of their job description. So it's just really important for me to, in this journey of mental health recovery, for all of us to feel safe. My experience was that I did feel safe and I shared. Long story short, in the end, I was not safe. It was not the best place to share. And so that really just exposed me to an experience that I had not expected, but everybody else it happens to. I just had not expected it. And so that's where you think about stigma and you're like, how can we reduce stigma amongst at least the people in my sphere? And so I feel like I'm blessed to be able to have that influence with family, with friends, because of my professional background and my personal experiences as a parent and myself included. And as a professional, it's just wonderful to be able to share with staff that it's okay. Let's just provide an environment where you're able to share. Now, I am clear that I do not want to be anyone's therapist. That's not what this is about, right? So we want staff to feel safe enough to share, because we need to embrace all of our identities. And it's only when we're together in this space that we could really do that. So I want us to be able to consciously engage all of our conversations. And again, my focus is professional. So I want us all to engage in those professional conversations. I expect it when you're with a client, right? But I'm saying your peer, your fellow clinicians, your fellow coworkers, to be able to consciously engage in conversations that are just respectful. Because just like in trauma-informed care, we learn to, you don't know who's in front of you. You don't know all of their experiences. They don't just vomit all of their experiences during the assessment period, right? We all keep things back. And so for a professional to just assume that everyone in front of you has traumatic experiences, not just lived experiences, but traumatic experiences. And having that exposure to that kind of training allowed me then to extrapolate it to everyone around me, including the staff. And so that's what I want for people, to be respectful to each other, because you don't know who you're going to re-traumatize. Just like with clients who you don't know their complete history. You don't want to traumatize. You want to provide a safe environment where you're just lifting people up and not tearing them down. And speaking of tearing down, I do want to speak to a specific situation that I had exposure to when I was a director of a PROS program. And so I had a clinician, so not my current organization. I had a clinician who approached one of our peer staff, was angry with the peer staff, and essentially told her, don't even think that you're part of the treatment team. You are not. You are a peer. You were just a client here months and months ago. And oh my gosh, that just hurt me so much. And of course it hurt her. It was traumatizing for her. And the idea is for all of us to recognize that every single person in our work is critical, and every single position is part of the treatment team. And if you know anything about peer specialists, then you know that they can be more effective in helping people to move forward in their life and find recovery than others. And I say others because you can be a clinician and have lived experience. It's just that job description doesn't require it to be known. So I continually encourage people. Everything in my work, at least everything that I believe I do in my relationships at work, are really to allow people the space to be themselves. And one of the things I also wanted to talk about was VCS. We have a tagline, saving lives every day. And I believe we do. I really do. And I agree with that. I also want to change the tagline, and we will be changing it to counseling for all. That addresses stigma directly, right? And it addresses equity and inclusion and belonging all together in that one statement. And so that is my purpose at VCS, is to really reduce stigma, embrace everyone, and for everyone to understand that, including everyone else into your life, into the work life, is really about accepting them and understanding them. And all of the mental health organizations are so adamant and so passionate about equity and inclusion and belonging, anti-racism, social justice. We are as well. But it's the including of the anti-stigma that's just such a natural fit. So I really do encourage everyone to be, every organization that's doing the anti-racism work, to be able to combine that with the anti-stigma work.
Thank you, Ruth. And Tiara, please share.
Hi, so forgive me, Jim, but can you please repeat the question?
So yes, so just in terms of the identities, your background and identity, for you, are there aspects of your identity that have made a difference, positive or negative, in dealing with mental health stigma in your experience? And or was there a time when you were receiving services that one or more of your identities was rendered invisible?
Okay, so hi, everybody. Good afternoon. I am Tiara Springer Love, pronouns she, her, and I'm the Director of Youth Power. And here at Families Together, Youth Power is a network hosted by Families Together, ran for young people and young adults, by young people and young adults. And we work to ensure that young people have meaningful involvement in all of the services that they receive. And definitely ensuring that we advocate for peer support within all core systems. And we do that through technical assistance, workshops, training, etc. And it's important to me because how I identify the pieces of my identity. I'm a Black, cisgendered young woman. I grew up as a Christian, and I live with a mental health diagnosis since 13 years old, and navigating these systems as both a young person, as a young adult. Both of the systems are very different, child serving systems, and also as a transition age youth, right? And I am the first out of my family to get a master's degree, right? So education level is also really important. And the aspects of my identity that have definitely impacted my need for services was definitely religion and my age. So as a young person, growing up as a Christian and having my first hospitalization at 13 due to a suicide attempt, this was unheard of. Right. So in my family, it was like, Black people don't do stuff like this. This is white people stuff. Right. And thinking about the ignorance of that statement as I've worked as a youth advocate and I'm now a director, and seeing how stigma really lives within different communities has definitely, and I know later on, we're going to talk about some of the solutions. So I'm not going to get too much into that right now. But I know for me, being a young person and and being told that my story was irrelevant because I was too young to have a story, right? Being depressed and having suicidal ideation and being told, oh, you have everything in the world. What is there to be depressed about? All you have to do is go to church, right? One thing that my mom did with me often was it put me in community programs, right? So as Randy talked about earlier, like, no, we were not going to see a psychiatrist. We were not going to get you treatment. However, I was on like every dance group. I was on the tennis team. I was like an usher at church. I was in the Girls' Rites of Passage program. Like every hour of my day was filled with something, right? So my mom's philosophy was, idle time was the devil's playground. So she did everything to make sure I wasn't idle, right? So as a young person, and then when I became a youth peer advocate, working within the mental health field, stigma still existed, as the other panelists talked about. And some of that stigma also looked like me not being heard because I was a young person, me not being heard because people felt as though I didn't come to the table with as much knowledge or experience as they did, right? So when it comes to the aspects of my identity that really supported and aided my process, it was definitely spirituality and age. And as I am getting older, right, you can't be young your whole life. Some of these things still exist. So I'm gonna leave it at that for the sake of time.
Thank you, Tiara. So thank you all for sharing all of these experiences. And to some degree, some of you have already begun to address the next set of questions, which is around, what can we do? Or what are the things that we could do to either reduce stigma or minimize the effects of. Randy, you said something that a couple of folks said something to the effect that stigma hurts. And I think that it's an interesting point of view, and folks have sort of talked a little bit about some of the things that you think we need to do to change. I want you to sort of share with me what your thoughts are, and it seems to me a lot of the things that folks are talking about are kind of the within the communities. And you said it, Tiara. You said that I think the word you used was that stigma lives within communities. Thank you. And so there's that aspect of it. There's the within community work that oftentimes needs to be done to reduce stigma. And then there's the larger systems issue. And I think, Ruth, you talked quite a bit about those larger systems issue that we need to be mindful of and addressing. And so I want to come back and see, what are your thoughts about what are the things that we need to do within groups to reduce stigma? And then what do we need to do with regards to the larger systems that promote stigma as well as other forms of
3 o'clock.
Is that for me?
Please feel free to start.
Thank you everyone for sharing. I really appreciate it. And yeah, one of the things that came out of it, listening to everybody, and what stood out to me is like our communities, that's where it needs to start, because it's so much corrupt. There's so much misunderstanding, so much mistruth that is killing people. Mine started in the home, then I got it out when I ventured out into the streets, and then getting older, it just kept, it kept building up. This intersectionalness about mental illness, and being gay and being Black, and it spread, and the races and the trauma, and it just kept growing. And if you never got no care when you were young, dealing with the first problem, now you got all this. So yeah, the community is really important. And I think the young lady talking about growing up in church, because I did, and I grew up loving the Lord until everybody told me the Lord didn't love me because mental illness wasn't of God. Homosexuality, it wasn't of God. Using drugs wasn't of God. And they're right. But I didn't have any other way. But who I was, I needed to be okay with. And I think God doesn't make junk. He made me for a reason. And now my life has been shifted and shaped out of all that turmoil to be this beacon of light to people like myself. And that's why I'm doing what I'm doing, to say you're all right just the way you are. And you can move forward. And with the right people encourage you and supporting you and validating who you are. All these things, my mental illness, my gayness, my partner, I still love to dance. All that was brought out, that it was okay because there's other facets of me. But when I was young, only thing that stood out is that you are gay with a mental illness. Shut up, sit to the side, and don't let nobody see you. And it wasn't any support. So yeah, the community and the churches were just even worse. Let me tell you, and don't get mad for all you religious people. I'm spiritual, so I feel different. I got tired of these men slapping me with that damn oil. I wanted to fight. Nobody was going to slap me upside my head with some oil 4 times telling me it's not done yet. Well, it's done now. Don't hit me no more. And I was abused in church. And it turned me away from God. It just made my mental illness, my self-worth, my self-esteem. And it started right before I ventured out, before I got 18 and 19. I was so devastated as a child in my own community with the people I thought were going to be loving and nurturing. They abandoned me. So I really want to emphasize that it's really important that we reach out to these communities, go into these churches, go into these social worker offices that are professing to be a support, and let them know it starts with compassion. It starts with compassion, because of compassion, I'm here. You know, I came out of jail in 2009 because of the compassion of this psychiatrist that sat and talked with me and gave me some insight that you're more than that. And that you do have dreams. Let's chime into it. And out of that, I joined, came out of jail. I went to school, got my CASAC. I got into an internship, and then I got certified, and I raised every year being at Rainbow Heights to be the director for the last 5 years. Don't tell me God didn't make me for a reason. I'm here to stand, wave a flag that we all have value. We all have a purpose, and we all deserve to be treated in a dignified, respectful way. Thank you.
Thank you.
And Randy.
Others, who else has thought? Thank you, Randy. Others who thoughts about what are the things that we need to do to reduce stigma or mitigate its effects?
Catherine, you go first.
Okay, I wasn't sure what was about to happen.
I know, me too.
So I will, first I'll introduce myself a little bit. So I am, as described earlier, I'm a research fellow, but I'm also a psychologist. And there's so many things that are being said that are resonating so strongly with me right now. Specifically what Randy was just saying also about just going into the community and how a lot of times people are not brought to a psychologist. They're not going to be brought to a hospital. And there are programs that are starting where they are trying to okay, maybe we need to think about things differently. Maybe if we can just train some people in the community to do some brief intervention, then we can start breaking down these walls. We can make church feel like a safe space where we can talk about mental health, and we can say, all right, if we need more help, that's okay too. And really just opening up those things. And so those are happening, and it's really exciting. And I think it's so incredibly needed. Another thing that was really popping up for me was a lot of my work that I have done. I've worked with adults, but I've also done a lot of work with children and adolescents. So a lot of people are talking about parents and how difficult it is for parents to accept, understand, see their children as needing something a bit more. And I've heard the things of Black people don't have mental illness. We don't do this. Or I've experienced worse. So what do you have to be complaining about? And I think a lot of this is also just about redefining strength. What does it mean to be Black cultural strength? What does it mean to be strong? What does it mean to really just be who you are and say, yes, intergenerationally, we have experienced so much and we got through it. And that doesn't mean then that we don't want to offer help when the next generation does maybe need a little bit more. And really just thinking about it that way. And I have more I can go on. I don't know if we want to switch off, or I could just keep going. All right, I'll keep going. And then I think my thing that I would really want to say we can change or work on to reduce stigma is mental health professionals need to work on rebuilding trust with the communities. There's been a lot of harm done, whether it's providing inadequate services or telling people that their identity is an illness, or just there are so many things. You can go down the list of the things that mental health communities have done to people. And so really just taking a step back and listening. And it was one of the things I was going to say, but Randy said it also, of the therapist can't walk into a room and just say, like, this is what's best for you. Taking a step back and listening. What does the other person say that they're needing? We know empathy is really what breaks down stigma. And so whether or not you're professional, recognizing that you don't have the professional opinion on someone else's life. Like, what do you need to know? What are barriers that maybe you weren't expecting to be there that we need to take a step back and listen to? Validating things that are outside of a person's control, because also when people who have been marginalized in the past, who have had people tell them that their experiences are not important or that's not really what's going on, they're not going to say it again. They're not going to keep coming back and keep getting hurt. And so if someone's willing to open up to you, then taking that moment and making that worthwhile, because they're not going to disclose it again. And now there's a whole area of their life, if they're experiencing discrimination and you weren't there to really validate that they're not going to be able to keep talking about. And we know that harms self-esteem. We know that there are traumatic reactions from discrimination. There's so many ways in which this just continues to wear down on people. So.
You're absolutely right, Catherine. I wanted to add to what you were saying, and thank you so much. I loved everything you're saying. And Randy, oh my goodness, you're a rock star. But I wanted to add that, for me, a perfect example, my son was misdiagnosed a few times. So many of our young boys of color are misdiagnosed, and our young girls of color, Black and Latino girls who are looked at as being grown women in third grade and expected to hold it together. We promote and we foster masking for them, and the suspensions and just everything that we do to marginalize individuals early on. Part of this is all the systems responsibility, because this is what they have done to impact our communities. But at the same time, for our communities, we have got to start in the clinical world, in the research world. I put a call to action for everybody with several letters after your name. Humble yourself. We need to humble ourselves and understand the value of things such as practice-based research. I was saved as an adolescent by an organization called Mind Builders in the Bronx. And anybody from New York City, anybody from the Bronx knows Mind Builders. But when I learned to dance, when I was able to perform, when I learned art, when I learned to be more constructive, being a severely neurodiverse woman, it helped me to grow. So when you look at things that communities are doing for their community, every community has, we, especially in the Black community, we have our own leaders, we have our own belief systems, we have our own different lanes on the same human highway, but we're going at different speeds and we're driving different cars. So people have to come into our communities and look at what's working for us. Hence, practice-based research. Hence, be open to the fact that the clinical modalities we accept today and the way we do the clinical work today has to evolve. Otherwise, let's look at what we were doing 50, 60, 70 years ago. It was disastrous. And I dare say, 50 years from now, we'll look back and go, oh my God, what barbarians we were. Mm-hmm. So understand that humans are fluid. All humans are fluid. So if we start going into communities and being highly participatory and valuing what the culture values and understand it is equally as important as the clinical modalities, they need to have a mashup. There needs to be accommodations, like I said, and I'll keep saying accommodations, adaptations, and not just being person-centered, being identity-centered. Because I always say persons of color have never been allowed to be unapologetically themselves at every single intersection. A mentally ill Black man will die at the hands of the police. What is that about? So that doesn't help the stigma. That feeds the stigma. That feeds the stigma. So your fear, my fear as a mother of Black boys, is that their emotional issues could one day land them in a situation that can end their lives. And that's a fear that nobody should be living with. But it's also a fear that will foster the continuation of the stigma. So until the systems, the clinicians, the researchers utilize the community to inform the modalities, to create new modalities, create new approaches, to understand that everything as simple, and I'll give you a quick example. I had a barbershop I was working with, barbershop in Pennsylvania. The barber was giving haircuts, sensory-free haircuts to children with anxiety disorder and neurodiverse children. So you know what we did? We made him a peer support person, and now he has a support group. Now he cuts hair and he trains them vocationally in his barbershop. So when you look at things like that, we do tend to get into this field and kind of have our own little caste system. We don't need to do that. Every barbershop, every bodega, every church, every storefront, everywhere where people are doing something positive for their community is where the researchers need to be, where the systems need to look, and not say you dance to the beat of my drummer and I'll help you. No, to say, let me see what the beat of your drum is, and let me buy you a couple more drums. You know what I mean? So that's what we have to do. Develop our communities. And lastly, I'm going to say the other thing that is needed, public health wise, same approach. Back in the day, I grew up in New York City. Public health wise, they did it best, you know, in terms of awareness. I could get up in the morning, I could figure out what neighborhood I'm going to go to get a mammogram because the truck would be somewhere, you know, the awareness that goes around and the freebies that you get just from having events that help to foster that reduction of stigma is a very, very positive, and it is evidenced that does help to raise awareness. But again, you got to use the community.
And I'm gonna actually use what you've been talking about with research as a good segue. I know Catherine, who's on our panel, was talking a little bit about her research. I want to turn to our researchers and bring them into the conversation as well. So Maria Elena and Phil, please sort of bring us a little bit of what is the research going on stigma reduction efforts and what folks on the panel have been talking about thus far. Maria Elena?
Hello, everybody. My name is Marlena Lecas. I'm one of the researchers, but after what Kim and Catherine said, I don't think I can add much. You said it very, very well. First of all, I was really, really moved and humbled by your experiences, by every panelist's experience, and you really depict. I wish everybody from the research community was here to listen to your stories, because your stories exemplify how the interaction of race, gender, age, immigration status, religion, spirituality come together and make us all. And when we go and ask for help, most of the time, unfortunately, the clinicians focus on the diagnosis, or they focus on the race, or they focus on the gender, right? If you go to an OBGYN, they will focus on the gender, but they never do what Catherine and Kim suggested, which is kind of ask, right? Listen. Ask the person, you know, exactly what David and James did with the word cloud. We all live with these intersecting identities. And I want to say that research has done a very poor job at integrating all of the identities of the communities studied into our research. What we do is we prioritize the health diagnosis, right? We neglect what you all spoke about very eloquently, the intergenerational trauma, the experiences communities have that bring every time they go to an appointment. And just like Catherine said, if I go one time, I disclose, you know, traumas based on my other identities, my immigration status, what have you, my age, maybe my gender, you know, and you neglect to honor that and respect it and bring into the clinical treatment, I'm not going to come back. And then you're going to blame me for being non-adherent. But I want to tell you that very few interventions to date, based on the research, integrate more than mental health diagnosis. The few that do exactly what Kim and Catherine said. They do community-based participatory research. They all go to the community and they say, tell us what is important, tell us what we should do. You know, listen to my music from my community, and I will guide you as a public health researcher, as a social science researcher, to tell you where to go. You know, the other thing I want to mention is, and I would like to invite the researchers on the call especially to measure other things. Don't just measure the stigma of mental illness. Measure racism, measure sexism, measure genderism, measure homophobia or heteronormativity, because that way we can start finally collecting the data and put it together and recognizing how multiple intersecting identities are really affecting people's health, access to services, recovery. And I really liked what you said about strength and empowerment. I heard empowerment in everybody's story, right? I think the value of intersectionality is that it has disclosed us that even if I have multiple intersecting identities, that doesn't necessarily mean that I'm going to do worse. Because if, for instance, I can find support in my community, right, based on my race, or I can find support in a women's group, that can strengthen me and that can help me manage the stigma of mental illness. That's very important. And researchers are now just recognizing this thing. Intersectionality, that's why in my definition I spoke about oppression, but I also spoke about privilege. And just like Catherine said, look for the strength, right? Because we talk a lot about stigma and exclusion and oppression and intergenerational trauma, but communities have survived, and they have survived under very adverse circumstances, right? So it's important when we recognize other people's identity, in addition to their mental health challenges, to also look, where else can this person receive support? You know, what can strengthen them? One of the things I recognized in my own research is that when I would ask people about the stigma of mental illness, sometimes people reported experiences of racism or sexism. And we thought we were measuring the stigma of mental illness, but we weren't. So there are things we can do. There is a wonderful scale up there by David Williams that looks at everyday discrimination, and you can link it to different statuses. And I want to give a shout out to the younger researchers because they're doing a better job than we did. And Skylar Jackson in particular is using diaries and is saying to people, for 1 week, you record your experiences, both positive and negative. And then each person has the ability to say, well, this was linked to the fact that I'm gay. This is linked to the fact that I'm young. This is linked to the fact that I'm Black, or this is linked to all of the three, or 2 out of the 3. So I think this is very important. And then we can bring back these findings to the clinicians that then need to do what Kim said. In other words, humble. Just look at the data and ask your patients, ask the communities you work with, and learn from them. And I'm going to stop here and give Phil the opportunity to contribute.
Thank you, Miranda. Phil?
Thanks. Okay, so my name is Phil Llanos, and I'm a professor at John Jay College, and I'm an advisor to the OMH's anti-stigma initiative and stigma researcher. So I just wanted to highlight some things that were brought up that I thought really reflect some of the things that are researched, but not very much, but I thought they were very powerful. So one thing is something that Kim brought up was about intersectional sort of oppression feeding stigma within communities. And this hasn't been studied very much, but we did do a study, my own research group, where we looked at the association between experienced racial and ethnic microaggressions and the expressed mental illness microaggressions, we found there was an association between the two. So this suggests that there's this pathway between experiencing oppression and kind of expressing it toward groups within the identity group. So I think it's something that needs to be understood better, because a lot of this is also about protecting the community and trying to find a way to survive in a society in which there's so much discrimination against members of racial ethnic minorities. So I wanted to highlight that. I also wanted to highlight something that Ruth brought up when she spoke, which was about stigma within mental health professions. And I just wanted to emphasize that this is something that we're starting to understand a little bit more about, both in terms of what fosters it in training. And we did a study recently where we looked at that among clinical psychology trainees, and we found that emphasizing actually training in acute settings actually fosters stigma and increases it. So associated with increased stigma among clinical psychology trainees. And then also in terms of clinical psychology trainees and professionals feeling comfortable disclosing. So we have, but their own lived experience, and we have there's some evidence that sort of this hyper emphasis on competence, as being this thing that needs to be maintained at all times, and this idea that if you have any mental health experiences, that you can't be a competent practitioner, which is not supported. But there's this belief in that that's really emphasized in training, and it encourages people to hide, because then they're going to be seen as if they can't be a competent professional. And then also the second class status that some professionals convey to peer providers, and that was very poignantly illustrated by what you talked about. And then there's a lot of evidence that peer providers really feel that, even if it's not expressed in such a direct way as what you discussed. I also wanted to highlight that there was a lot of discussion about religion. I heard this from Kim, from Randy, from Tiara and Darlene, and all of this is really powerful. There's very little research on it. We did do one research study where we just looked at themes around religion among youth with early psychosis, and it wasn't something we were looking for, but people were bringing it up. They were bringing up how much they anticipated stigma from the religious community, and it led them to avoid talking about mental health experiences with their family members or with their existing supports within these religious communities. And then also how it discouraged care seeking, right? Because it's very hard to seek care without it being known when you're a youth. So it's something that really needs to be understood more. One last thing I wanted to bring up that I didn't hear anybody talking about something we've called dual alienation, which is where when you're a member of an intersectional group, you experience stigma from both sort of communities in a sense. And this is something that we found evidence for, where if you have, let's say if you're an LGBT person with mental illness, you might feel rejected by the LGBT community as well as the community of people with mental illness. And that's why places like Rainbow Heights are so important, because they provide a safe space for people to be both identities, where they might feel rejected in one or the other. So those are the things I wanted to highlight, and just really powerful illustrations of things that we've been hearing about, as well as some things that need to really be studied a lot more.
Thank you, Phil. Thank you, Phil. And actually, Phil, I think as you mentioned, I just want to highlight, the theme of religion. We hit a lot of themes: immigration, religion, race, sexual orientation, and so on. But it was striking how many folks talked about religion. I mentioned that too because Simcha Weinstein, who's in the audience today, he's going to be on our last panel, and he has a lot of thoughts about that. Rabbi Simcha Weinstein will be on our last panel, and I think there's a lot of talk about how to engage the faith community as an avenue towards reducing stigma. So there's a lot to talk about. Amazing discussion. I want to switch now to Q&A and give the audience an opportunity to please chat in your questions or any comments that you have and that you'd like the panelists to respond to. While we do that, though, please take a moment, folks, to chat in your questions as we speak. But while we do that, I wanted to know, David, can you bring up the the results of our word cloud. I'm curious to see it. And then again, oh, so here we go. A gorgeous word cloud. Oh, like right there in the woman, in the middle, mother, woman, female. As we talked about, we see religion, Jewish, in the center here, daughter. So many folks identify by their roles within a family. We see social workers, quite a few in our audience, as well as on our panel, and psychologists, so professional identities. We see queer, advocate, Black, so race, all of these aspects, just underscoring what the panelists have talked about. And if I can, just generally, just collectively, what the panel has said is we all need to be understood by all these different aspects of how we see ourselves. And what I'm also hearing is our systems, our professionals, and our providers out there need to see us, need to see people who are seeking services and getting help as complete and full people with many diverse aspects of who they are. So just an amazing, I'm just curious if anyone else has anything that pops out for them with regards to this word cloud. And so while anyone can sort of comment on that word cloud, I just want to also just check in to see how we're doing on questions. So give me a moment. And so yes, please, any questions that we have that are coming up? And I'm not seeing, oh, here we go, sorry. By the way, I also want to mention Phil's book, Written Off, Mental Health Stigma and the Loss of Human Potential. It's a wonderful book and really accessible. He really breaks down mental health stigma, what it is, why it's important for us to understand. I just want to send a shout out, Phil, like reading especially the opening chapters of that book just clarified so many things for me. Okay, quickly, rephrase. So again, I suppose for anyone on the panel, Sylvia has a question. What are the ways you have coped with the pressure with stigma? And so many of you have spoken about it. And actually, Tiara, I want to bring you in because I know you kind of said in your sharing your experiences that you were going to wait. I wanted to actually ask you, Tiara, if you want to share some of the things. How have you coped with stigma? Because I know you kind of said you would wait, but we didn't give you a chance to sort of share.
Thank you. I thought you forgot about me.
I will never forget you, Tiara.
So one thing that I want to just highlight and address are kind of what Ruth was talking about is like oppressive work policies. And one thing that I've done, I would just say in my professional life is just like any place that I've worked, it was like to just ensuring that I had access to tools and resources, especially being a person from like an underrepresented community, right? And like, I feel like with true opportunity and success and advancement, like if you're gonna say I'm underrepresented and I'm also not getting the same supports as my white counterparts, then you got to give me a little bit more TLC. You know what I mean? I don't have the same access to things that my coworkers may have access to. So really me doing research around, hey, from an agency, this is the kind of professional development that I need. This is the support from you that I need. And that has helped me when it comes to coping with stigma, because I'm also very authentic about my experiences, right? Like I'm extremely honest about my treatment and I'm open about it. Yes, there are things I don't have to share with my employer and I don't share everything. However, as a young person, navigating this world of work and also being a peer advocate and a youth peer advocate at that has been super beneficial for me. And then also finding like my person, right? So Kim and I work together, and Kim, for the most part, like me and Kim, we speak about these challenges. I talk to Kim about, and we both live in Albany, but we're both from the city, right? So there are also different aspects of living in Albany and then coming from the city and being Black in Albany, right? Like that was definitely a culture shock for me. So when I moved out here, the transition was really tough and I needed to go back to treatment. And I knew I needed to go back to treatment, but I wasn't as open about it because I wanted a Black therapist. There are not that many Black therapists in Albany, right? So even just trying to figure out ways to cope with it, I knew I needed help. I found me a Black therapist, right? After a bunch of research, doing a lot of research. But me being true with me being true with my employer, and then also building my support circle with like-minded people who also want to see me do well, right? Because I feel like sometimes I rain on my own parade, and life does that all by itself, right? Like I don't need to help it. So those are some of the things that I've done to help with like decreasing stigma and staying involved, right? Like as I was a little girl, I talked about my mother put me in programs, and she put me in non-traditional, or what we would call informal supports, right? Like maybe not formal support groups, but informal supports. I've done that for myself as a young adult here in Albany. So I've taken what I've learned from my past and I'm applying it to what I'm doing as an adult right now, establishing my career and who I want to be as a young professional as someone with a mental health diagnosis.
Thank you, Tiara. And Tiara, I think another question that came up was around help seeking. You gave obviously a great example of, just seeking professional help and looking for a therapist, a Black therapist, and finding one. Does anyone else want to address what are some of the other barriers to help seeking that were there for you related to this issue of intersectionality, if others want to share? I should say, and how maybe you overcame it, if possible. Yeah, Darlene.
Sure, not a problem. I just wanted to say that representation does matter truly. I think in searching for content, social media content of people who look like me, or searching for a therapist of somebody who can understand what I'm going through, I think that's something very important. But then also, not having the words, not being able to really discuss mental health. It took me a really long time to talk about it, I would say, in treatment. And so I think we've mentioned this before, just the diversity of interventions and ways that people express their narratives through art, through movement, through dance, through all kinds of ways of just being open to people's cultures and the diversity of ways that people can share their wellness and the ways in which that they can recover. I think that as providers, we really need to be open to that and, sort of give voice to the sort of creative minds of people who might not have the words for it, but have other ways of expressing what they'd like to share.
You're on mute.
Thank you. Sorry. And I did want to sort of go back. A number of questions have come in. And Phil, I want to sort of direct this to you, but of course anyone can. A number of questions have come in on the subject of professional stigma. And I know you talked a little bit about it in your summary, but I think folks are asking a little bit about what do we do about that? How do we address that? And what are some your thoughts about that? Of course, anyone else can answer as well, because we have a few folks who identify both as peers, professionals, and people with lived experience. So please.
Yeah, I despair of it a little bit because I was a director of clinical training, and I really struggled to change the culture within my own program that I was at least in supposedly directing. And the forces are very powerful in the field. So trying to work against that is really difficult. I would say, number one, bringing in people with lived experience, for students and your peers to meet, and having them recognize, their expertise and their amazing accomplishments is essential. Doing that is something that I've striven to do, but when you bring it up, there's not a lot of interest, among my colleagues and the students. So you have to kind of force it, and then people don't like anything.
I'm interested.
So, yeah, I know. So anyway, it's just something I struggle with. Yeah, and I've spoken to colleagues in social work as well about how this is, something that doesn't necessarily happen in a lot of social work programs either. So, but I can't speak for social work, but this is what I've been told by.
And I think, and I think one of the other things, and Ruth, I want to certainly get your thoughts, but I think the other sort of area that folks are asking about, some of the things that you shared, right? Their own mental health stigma regarding sharing and talking about their own struggles and their own challenges. I think you mentioned earlier that sometimes the perceptions of not being competent or being judged, and I think Ruth, you spoke very clearly about this aspect of it, right? Within the community around mental health stigma. So, but Ruth, did you want to add anything?
You know, when you think about anti-stigma work, it's almost too big to deal with. And so when I look at my identity, I intersect in so many ways with mental illness. But my largest identity in terms of this topic is really as a professional. And so in my role at BCS as the CEO, it's really important for me to share my experiences at this organizational level with other mental health organizations. So we talked earlier before about anti-stigma work and really folding that in to our existing work with anti-racism and social justice and equity. And so to be able to warn organizations just like mine not to go to the extremes. And so how many of you have seen organizations sanitize through their policies, sanitize everything so as not to offend? And so my message in my organization and my message to my sister organizations is really to embrace difference and take those sanitized policies out. And you know what? Let's embrace each other's differences. And if you have a question about the flag in my office, whether that's an American flag, a Puerto Rican flag, or a rainbow flag, whatever it is, ask. And our role for our teams is, and this speaks to the culture change, is really to educate and expect respect. I can't tell you what to believe in your personal life, obviously, but I can tell you how we need to work in our organization. And so, yes, it's deeply based in recovery-oriented care and in just this honor and belief that everyone has a right to their identity.
Yeah,
I just wanted to comment on the workplace, stigma. I work really hard to be able to show myself as a professional, and I work with a lot of professionals are from the old school. They're still not happy with what I bring, but I'm kind of a stand-up person. But the stigma that goes on with not wanting to respect us, and we're doing more of the work and getting more connected to the clients that have been not connected, and hearing from clients that have never said anything. But you still have people within the workplace that don't like us, and more to what Ruth said, they will speak to us like we're second-class citizens. I've heard people say, well, we can't expect too much of a peer. Maybe one of the social workers could do it. But it wasn't as harsh as what Ruth explained she heard, but it still hurts that way because we bring something. And we're not trying to be social workers. We're not trying to be psychologists. We're trying to be peers to connect to people to get them where they want to go. It's not about us. Don't make it about us. And sometimes because we don't let them co-opt us to talk like them, they get angry, and it becomes a competition. And it's never a competition when you're working about trying to better a client and trying to help a client. And to what Phil about being LGBT, it's just, we have stigma in everything. And yeah, I deal with a lot of LGBT clients that are so traumatized by the community because they don't got what they got, and then they have a mental illness and they're outcasts and they're talked about and they're shunned and their self-worth and their self-esteem and suicide and depression and all these things happen because no matter where you come from, there's some inside. The people right next to you that should be supporting you, that look like you, do the worst damage to you, and it really hurts you more because you think we're the same. I'm Black, why are you treating me like this? I'm gay, why are you treating me like this? I'm here on this team doing what you do, why are you treating me like that? And these stigmas that go on are hurtful in so many realms. And it kind of, for me, It takes a lot to work with these professionals that don't see what I bring and don't value me for what I bring. But then I have to, sometimes I get asked to leave the room because I stand up a little bit too much, but I let them know that I'm not trying to bring anything but what got me here. And if that's not good enough, why am I here? Because I really believe that we need to integrate peers in everything and then listen, because we're going to get something that most of you don't get. And don't be threatened by that. The goal is to support the client, not about you or I.
Yeah. Thank you, Randy. And Randy, I'm going to give you the last word on this because I think we have a couple of things to tie in. But when you say that, and I think another theme that's come through, Marilena talked a little bit about this, even framing the question is how intersectionality and how interacting with the systems that are there to help oftentimes might render one or parts of our identity silent, invisible. And I'm a big part of what you're talking about, Randy, and what you've all talked about is this notion of voice, this notion of being able to be identified and seen as a whole person with a full and complete voice and ability to communicate and talk about all those, and opportunities to do that within the helping professions and the helping systems. I did want to, so if you can bring it up. So there are a couple of questions, but my fear is that we're going to run out of time. And I think the reason why we're okay to continue is that we do have 2 more roundtables. So for those of you who may not have gotten your questions answered here today, please bring them to any of the future ones, especially the last one where we're going to talk a little bit more. And there were a couple of questions in there about what we can do in these larger systems to address some of the policies that are in place that might interfere with help and reducing stigma and getting folks the help that they need. So I encourage you all to come back to the next 2. If you can, David, if you can bring up the slides. Just to remind folks, as we mentioned, so first, these are a few resources. Again, you can register and learn more about the upcoming mental health roundtables at behavioralhealthnews.org/stigma -roundtables. And please register for those and please send the information to your networks and others that you may know. You can view the special issue on Behavioral Health News, Understanding the Impact of Stigma. That's the one that was done over the summer. It is a wonderful issue. If you want to learn more and understand more about mental health stigma, that's a great place to go. And also, if I understand correctly, David, there's a new issue coming out. So as David mentioned, you could always put in and provide your thoughts about stories that you would like included in that next issue. And then visit the New York State Office of Mental Health Resources for publications on the issue. And Suzanne, I don't know if they can get issues specifically around mental health stigma, but I'm sure there's plenty of materials in there as well.
Not as many as we would like, Jim, but we're working on it.
Great, Suzanne. And then, so the next slide, please, and then we're gonna. And so the next roundtable, again, is going to be in 2 weeks on February 9th. It's going to be a wonderful panel of folks in the media. We have reporters from the New York Times who are going to be there, folks from Huffington Post. We have someone from Buffalo, Toronto Public Radio who has a show who's going to be addressing issues, and Micha Hirsch-Ito, who's going to be talking about social media and how we can use social media to reduce stigma. So we really invite you to that one. It's going to be a wonderful panel discussion, and we want to get your thoughts about mostly what the media can do to help. We know all the things that media can do that obviously can hurt the cause of reducing mental health stigma, but we want to focus that one on what the media can do to help. And I want to thank you all for joining us today. I want to thank our panel. I want to thank the full panel, both those of you with lived experience as well as our researchers, our wonderful researchers. I want to thank you, the audience, for joining us and being a part of this discussion, and for the questions that you've put in, and for seeking more information and understanding about this really critical issue. And we look forward to seeing you all. Oh, excuse me. And of course, I want to thank the Office of Mental Health as well as Mental Health News and Education. So thank you all, and we will see you again in 2 weeks.